And if folks can just put their name and contact info, I'm sorry, their name and organization in the chat, that would be very helpful. Thank you. Okay, well, it's the top of the hour. So, my name is Heather Carter. I'm the Dementia Services Coordinator at the North Carolina Division of Aging. And this is the Dementia Friendly Communities and Hospitals Network meeting. So if this is not the place that you wanted to be, you can hop off now, but we would love for you to stay. We're going to have a great presentation from Dr. Mia Yang regarding the GUIDE program or the GUIDE model through CMS. But before that, I wanted to run some polls with everybody. So I guess I'll wait just another minute or so. But so these polls are about the videos that were created regarding dementia by our partner UNC Cares. And just wanted to see if the outreach efforts that we conducted resulted in some more knowledge of the videos themselves. So I'm going to launch this first poll. So it looks like we've got about 11 responses, 14 responses, and we've got about 20 people on. So I'll give people another couple minutes to complete the poll. And thanks for your patience. This is my first time running the polls. My colleague Casey usually helps me out with this, but I think I figured it out. So we're going to give it a whirl.
Doing great, Heather.
Thank you, Casey. I appreciate that. And I like your purple background too. It is Older Americans Month.
Thank you.
All right. Well, looking at the poll, it looks like over half are members of the Aging Network, and almost a quarter are healthcare providers. Excellent. Current or former caregiver of a person living with dementia, about 10%, and then other. So welcome, everybody. And let me go to the next poll, which I will launch. So we do have the videos related to dementia on our Dementia Capable NC webpage. So it looks like most people are aware of them. That's great. So I guess our outreach efforts worked. Allie? I'll give people a few more minutes. Okay, so it looks like 75% of everyone is familiar with the videos of those who responded. Wonderful. So I will launch the last poll. So we've got about 10 responses and 24 people on, so give it another minute or so. It really is a long period of time, a minute with silence. So I'm trying to get more comfortable in that and trying to remember that when working with people living with dementia, that they probably need some extra time to process before responding. So it's okay to have silence. All right. Well, I'm going to call that one. So thank you all for participating in that. Um, Dr. Yang, it looks like, was able to join us. Fantastic. Hi, Dr. Yang. She's a trooper. She is in transit to a conference. So thank you so much for making the time to meet with us and present to us, Dr. Yang. Anybody have anything they wanted to share before I introduce Dr. Yang and have her get started? Okay, well, that's fine. Um, Let me introduce Dr. Yang. Mia Yang, MD, MS, is an associate professor in internal medicine geriatrics at Wake Forest University School of Medicine, part of larger Advocate Health. She is a clinician researcher in dementia care models and was a co-investigator in the Dementia Care D-Care study funded by PCORI and NIA to compare health system-based dementia care with community-based dementia care. Work from D-Care and other evidence-based care models led to the Center for Medicare and Medicaid Innovation, CMMI, releasing the GUIDE program. Guiding an Improved Dementia Experience is a multidisciplinary comprehensive dementia care program that also pays for limited respite care. Dr. Yang is the Advocate Health Enterprise Lead for GUIDE programs across 4 sites in 3 states. Very impressive and very busy, Dr. Yang. So very interested to hear more about GUIDE, and I've had the privilege of hearing Dr. Yang talk about the Winston-Salem site during some of the meetings I've been able to participate with the GUIDE providers. Dr. Yang, do you want me to advance your slides?
I can share my slides actually. Can you hear me okay?
Yes, wonderful.
Okay, perfect. Thank you so much for the introduction and
Thank you.
appreciate everybody joining this session. Put this into the slide mode. All right, can everyone see my slides?
We can't hear quite like we could hear Heather. Is there a way the volume you can speak a little louder?
Sure. Are you able to hear me better now?
A little bit more.
Yeah, a little bit louder, please. Thank you.
What about now?
Mm,
No? How about now?
yes, I think that's much better.
that any
Much
better?
better? Excellent. Thank you, Dr.
Okay.
Yang.
Yeah, thank you so much. Sorry about that. So yes, I'm here to talk about the guiding and improved dementia experience. And just so folks know that Wake Forest University School of Medicine is the academic core of Atrium Health. Wake Forest Baptist Medical Center merged with Atrium Health a couple years ago, and then Atrium Health merged with Advocate Health, which is based out of the Midwest more recently. So now we're this big multi-state institution. It does relate to GUIDE, but that's why I wanted to give that introduction in the beginning. So let's start with a hypothetical but very real situation where Margaret is the person who has been diagnosed with dementia, and her daughter Kathy is her caregiver. They're both worried about Margaret's future and being able to meet her needs at home. On the left side is kind of the common current dementia care experience, and on the right is really where we hope the guide models can meet the needs. So usually, when people are diagnosed, they don't know how to access resources or support. Margaret and Kathy might be searching the internet for information, or they might be coming to NCDHHS websites. Unfortunately, Margaret starts to take the wrong medication, and Kathy has to take on more of the responsibilities of managing her medications. Understandably, her daughter Kathy becomes stressed when Margaret starts to wander and becomes aggressive. Unfortunately, Margaret wandered away from home at night and was taken to the hospital. And Kathy had to plan for a neighbor to stay with Margaret whenever she needs to run out. And unfortunately, the neighbor cancels last minute, and Kathy misses her own doctor's appointment. And I think all of you on this call know that this scenario happens more often than not. And the guide model really tries to meet the needs of the caregiver along with the person living with dementia. So within the guide model, both the person living with dementia and their caregiver receive a comprehensive assessment, and that can include a home visit to identify safety risks, especially if the person is at a moderate or severe stage of dementia. We also prioritize the caregiver's needs, and the care team works with Margaret and her daughter to develop a care plan based on their individual goals and preferences, screen for social determinants of health, and refer to community programs if applicable, and also teach Kathy, the daughter caregiver, on what to do in case Margaret tries to wander at night. Instead of potentially going to the hospital, Kathy could call the 24/7 phone number that is associated with a guide team and get support even at night to stay at home, because we know that the emergency room and the hospital can be a dangerous place for people with cognitive impairment. And when Margaret's dementia progressed to the point that she really needs around the clock help, Margaret gets this limited in-home respite care so that Kathy, her daughter, is able to attend her own doctor's appointments or just get a little break. So as Heather has mentioned before, a lot of this work is based on a number of different evidence-based dementia care models. I'm talking specifically here about the DCARE study, which we were involved in. It was a national study where we enrolled more than 2,000 dyads, meaning there were actually about 2,000 persons living with dementia and 2,000 caregivers who were enrolled as a pair, comparing community-based dementia care model using social workers and the Benjamin Rose Institute model of care consultation, compared with a health system-based model using advanced practice providers such as nurse practitioners and physician assistants. And this was based out of the UCLA Alzheimer's and dementia care model. As you can see, at the duration of the study was really mostly during the pandemic, and that did affect the study intervention because a lot of things were just not available during the periods of the study. And we know that despite the evidence, we really needed a payment model to pay for this type of comprehensive care because the fee-for-service type of care is really insufficient to pay to meet the needs of the families. When was announced by CMS in 2023. We were all very excited, and that our experience in the DCARE study directly relates and has a lot of similarities with what GUIDE requires. So we ended up submitting 4 applications, and our site was approved as an established program starting to enroll since the summer of 2024. And then the other 3 programs within the Advocate enterprise, which I'll talk more about our state-specific GUIDE programs in a later slide. Around the country, there are about 390 programs that have been approved by CMS, with most of them starting this summer. So a very timely discussion for those of you who have not heard about GUIDE to learn about GUIDE now. Just more detail as to what the model is about. It really has 3 main components. One is care coordination and management from an interdisciplinary team. And this is really to develop person-centered care plan, managing the person's dementia and any co-occurring conditions with very frequent ongoing monitoring and support. There is a very structured and significant caregiver education and support program where we must teach the caregivers skills on dementia and communication, offer support groups, as well as get them connected to a program care navigator to help problem solve and connect them to resources. And then the last piece, which is a really exciting part about this program and remains the only program within Medicare that pays for respite care. So unlike Medicaid, Medicare really has not paid for respite. This does have a cap of $2,500 a year, but it's better than zero. We're required to provide in-home care through, paid caregivers, or can include adult day programs as well as facilities that offer 24-hour care. These are the 9 care delivery requirements that all GUIDE programs have to meet as a part of this program. So the comprehensive assessment and the care plan on the left really go together. And that can include that home safety evaluation. Different teams, different GUIDE teams deploy different personnel to do that. We all must provide 24/7 access. So this is not the Alzheimer's Association 24/7 hotline. It's really supposed to be basically an on-call service that can communicate directly with the GUIDE team. The ongoing monitoring and support, we contact our enrolled participants on a monthly basis because that's partly how the programs get paid, through a per member per month payment. And connect people to community referrals, support coordinations of care, caregiver education, managing and reviewing medications, as well as supporting transitions of care in and out of hospitals and or other rehab facilities. So who is eligible? This is a model that is released by CMMI. So they really only have control over people who have traditional Medicare. So you get the Medicare directly from the government, not from Aetna, Humana, United Healthcare, or another Medicare Advantage program that is the deliverer of Medicare. And that is probably the biggest barrier to people participating right now, because in the state of North Carolina, we probably have anywhere from 65 to 70% of eligible Medicare participants selecting a Medicare Advantage plan rather than the traditional Medicare plan. People have to have a dementia diagnosis. If everyone is if everyone in a family knows that a person has dementia and it's just not documented or coded, our clinicians can confirm the diagnosis and make sure that there aren't any other potentially reversible causes that could be contributing, and that they cannot be part of a hospice or PACE program. PACE is called the Program for All-Inclusive Care of the Elderly, which I know we also have a number of those in the state. And a lot of times they include both Medicare and Medicaid dually eligible beneficiaries. And then finally, they have to not be residing in a long-term care nursing home. And this means that people who are in assisted living and most independent living are still considered eligible as long as those facilities are not considered in a long-term care nursing home. And I cannot see the chat, so if people have questions that come up, please just unmute and feel free to interrupt me. All right. So like I said, we have 4 programs within the Advocate Health, with the Charlotte program starting this July. And then these are also some other digital companies that have been accepted as guide participants. You may hear about some of them around the state because they might be in North Carolina. For example, Ripple Care, which has partnered with the Alzheimer's Association. They're currently only in 3 states. And I think Illinois is one of them, but not yet North Carolina, but plan on expanding. The Cranial Metrics program got their training from Johns Hopkins and the Mind at Home program, but it includes others. I think the potential downside for these dementia companies is that they're not as integrated within the patient's existing healthcare network because the electronic medical records don't connect to each other. Here are the programs in North Carolina, the established programs. We are part of one of 7, Hospice of the Piedmont in High Point, Authora Care based out of Greensboro, a small practice run by neurologists called Memory and Movement in Charlotte, Hospice of Wake County in Raleigh, and then Hospice in Wilmington, and Memory Care out of Asheville. The other programs listed below are starting this July. In totality, there are 14 programs in the state that are offering guide, and patients and families have the option to choose one. You don't have to pick the one that is the closest to you, and a lot of these, pretty much a lot of these programs can have a pretty wide geographic area. On a national level, this is a survey that was administered by another company called Iona Care, just asking those who are participating in Guide to select what type of organizations they are. And the highest number is actually people who are from a hospice or palliative care agency. And the next highest are healthcare systems like us, followed by physician group practice, digital health companies like some of the ones I mentioned before, home health agencies, and then the least common was community-based organizations. This is kind of what the timeline has been. We had to submit papers to CMS back in May of 2024, and then we started enrolling not exactly in July, but August of 2024. The other new tracks have this 1-year pre-implementation period. And then we had to submit data to CMS on a regular basis, and the new tracks are starting this July, and that this is an 8-year demonstration project, and that all models will end in 2032. So this is just an example of the intensity of ongoing monitoring and support. The guide basically through standardized questionnaires based on the person with dementia's functional status and their caregiver burden fall into one of these 5 categories. 3 of them are for beneficiaries with a caregiver, and 2 are for beneficiaries without a caregiver. Medicare calls people living with dementia as beneficiaries. and I sometimes use the word patients, but they really mean the same thing, the person living with dementia in the community. For, as you can see, most of these dyads or individuals we have to contact on at least once a month basis, and some of them actually twice a month. Short, messages or my chart messages are actually not sufficient to meet this minimum contact frequency. And it has to be a phone call at the minimum, if not an in-person visit or a virtual visit. So more on respite care. This is for the subset of folks who have a moderate or severe dementia, meaning that they need at least assistance with some of their personal grooming tasks, such as bathing or dressing, and that the caregiver is probably scoring at least moderately high on the caregiver burden score. Unfortunately, unlike Project Care, which is another program administered within North Carolina, this respite money cannot be used to pay caregivers directly or pay neighbors or friends or church members. Because it's a Medicare program, we have to deliver the care through licensed organizations. And this is the amount that Medicare pays us, and all guide organizations have to pass on these respite funding 100% to the agencies that are delivering the care. We don't take any middleman cuts, and these are the prices, and they're actually geographically adjusted. And in North Carolina, those rates are actually lower than what's listed here, which makes it sometimes not a very financially incentivizing pay rate for some agencies and day centers. It is also very difficult to, at least I have found, for facilities to agree to provide respite, just because $2,500 really can only get you at most a week in a facility at the rate of $260 per day. And a lot, as you guys know, some of you may know that a lot of these facilities require at least a minimum of 2 weeks stay, if not a month. So that's already more than what $2,500 can pay for. This is kind of the process that we have that's generalizable to other guide programs as well, as to how the respite funds flow. We have to sign official partnership organization agreements between the guide program and the partner that's delivering the respite care. We have to submit this information to CMS to approve. They have to run checks to make sure that organizations have never committed Medicare fraud. And then the respite services can begin. Once the service is delivered, the partner organization will invoice us on a monthly basis. We bill Medicare using specific respite G codes and the electronic medical record. And then CMS sends this money to us and then passed on to our partners. Even though we have been enrolling and delivering respite care for most of this performance year, there has been a significant delay in the CMS payment for respite. And this is just basically my final slide for those who live within those green counties. If you are interested in our program, this is how you can reach me or reach the guide team directly. You don't need a referral, so people can self-refer, but certainly we want to work with your existing clinicians and make sure that we're coordinating care and keeping them in the loop. So that's all of my slides, and I'm happy to take questions.
Thank you, Dr. Yang. That was really helpful. And I'm glad that you addressed the question about consumer directed, because that was something that I was going to ask, if caregivers could hire, a neighbor or a friend or what have you. So thanks for that clarification. So I do have a couple of questions. The required contacts that you were saying are to be performed, can they come to the guide office, or does it have to be a home visit or a phone call? Like, is the guide facility, what does that include? Does that include like yourself and other clinicians?
Yeah, so every guide program might be slightly different. So for us, we have two APPs who have been very experienced in dementia care. Both of them actually worked on the DCare study with me. And then we have 1.5 social worker, that the other half of a social worker is currently on maternity leave.
Oh,
We have a recruiter slash scheduler. She's actually a CMA who has been in geriatrics for a long time. She's really great about kind of reaching people and getting them scheduled. And then we're also having a part-time community health worker who is doing those home visits. Different programs may have different personnel doing the required task, and CMS really doesn't require a particular discipline to do it, as long as it's done and that we can show that people have done appropriate training, both sort of digital asynchronous type of training as well as in-person training. And those are usually done by me directly through our interdisciplinary team rounds that we hold on a weekly basis. And that, yeah, so that, I hope that answers your questions.
Yeah, that's really helpful. And then I know that you said the respite's got to be provided by a licensed entity. Can it be an adult care home, which in North Carolina includes assisted living, or a nursing home or skilled nursing facility? It can be either.
It cannot be skilled nursing. It
Cannot be
can
skilled
be,
nursing.
yeah,
Okay.
it can be assisted living, independent living, adult day. But I mean, I think it's possible that other people have had better experiences finding facility-based respite than I have personally. I just have, we're all required to provide in-home respite. The adult day and the facility-based respite are consider optional. So some
Okay.
programs may offer them, especially if they're hospice or palliative agencies who may have their own respite as associated with hospice, and can kind of do that in-house. But I know for many healthcare systems, at least the ones I've been in touch with, the amount of reimbursement for that per day of respite really is not very enticing,
Yeah.
even if you live in a fairly low cost of living area like Winston-Salem.
Right, right. And then what about family care homes, that are licensed for 2 to 6 residents? Is that
So
available?
yeah, as long as they're able to sign a participation agreement and that, they don't have to bill Medicare. So like, for example, we partner with the Tab Williams Center based out of
Mhm.
Senior
Yeah.
Services in Forsyth
Yes.
County. And that's not a program that
Right.
usually bills Medicare. For any agencies that do not bill Medicare directly, we actually have to submit the social security number of their like CEO,
Oh, wow.
because
Okay.
Medicare wants to make sure that you haven't committed Medicare fraud and maybe just change the names of your company, because some people do that, to make sure that everything is in compliance and that we are delivering good quality care.
Excellent. Thank you so much. Does anyone else have any other questions for Dr. Yang?
The one question that I have, and I am familiar with Guy because, and thank you for sharing again, because I always learn something new. I'm kind of aware because I'm in the Kernersville office, so I'm in your catchment area, and I know there's other guide programs in our area that's reached out. My one question would be, because we do make referrals, folks call us all the time looking for resources. Is there a catch in this guide system? Like if I send you a referral, but they're also connected with another guide program, would they be duplicated in the program, or is there something to say you can only get it from this one program?
So people have the choice to choose which guide program. So, Forsyth County, Guilford County, a lot of counties may actually have a lot of overlapping between different guide programs. So we cannot tell people which one to select, but people can only align with one guide program at a time. So they can't be getting services from a Wake Forest guide program and an AuthoriCare guide program at the same time. Obviously, people could choose to disenroll from one guide program and go to another guide program, but all of that has to be basically uh, officially approved by Medicare, almost like you're getting a new insurance kind of thing. And there's a little bit of a delay in that approval. So every time you switch to a program, there may be a slight delay in some services because we have to wait for that Medicare approval in order to say, partner with our respite organizations to deliver that care.
Good to
Yeah.
know. Thank you.
Yeah, absolutely. And I think, because Medicare doesn't require, who does the which type of personnel does the care delivery. Some programs may be mostly the care navigation may be mostly done by folks who are not licensed but trained in dementia care. Versus, I think our program. Obviously, I'm biased, but I do think that we have very experienced professionals, both LCSW, so licensed clinical social workers who have experience providing mental health therapy, if that's needed for the caregiver or the person living with dementia, as well as APPs who are very experienced. Obviously, that makes our program more expensive to deliver when you think of like the money that comes in from CMS. That's the same regardless of who delivers the services. I would just I don't know because we were so early in the delivery of guide that none of us really know if that makes a big difference. I know so this gets back to the DCARE study in that we were comparing, say, a social worker within a nonprofit like senior services versus a healthcare model. The study, I didn't talk about the results of that study here because I didn't want to run out of time and really focus on guide. But the main results did not show a difference between the two interventions in terms of caregiver burden. But I think that has to be said with a caveat in that, the original model for the health system side is a in-office based intervention that then converted to telehealth. And, especially in the beginning of the pandemic, a lot of telehealth wasn't virtual, it was audio, which turned into very similar to what the care consultants do using the Benjamin Rose model from a community organization. And then, respite programs like adult day programs and many other community resources were also temporarily closed down during parts of the pandemic. So basically everybody got the telephone call, which was great, still better than usual care in some ways, but not the full and original envisioning of the model comparison. And nobody could have predicted the pandemic, and here we are. Does that answer your question, Adrian? And then I think I didn't. Yeah, I don't think I fully answered Heather's question earlier about what type of is it in person, is it telephone? I would say really for us it really depends. We have some patients who are very hard of hearing and they cannot really do a virtual or audio visit, and we have them come into the office. But most of the people because it's a monthly touch point, we are doing a lot of phone call only, but really just depending on what's going on. And I'm sort of in there coordinating some of this because some of the messages come to me and we discuss cases during our weekly IDT round. So sometimes I say, oh, this family might need a little bit more medication management. So we'll have the APP do like a telehealth visit with them versus, this family really needs to talk with the social worker and change perhaps how they're communicating with their loved one because they're, fighting with each other. And sometimes it's like they're just doing fine, in which case we I have our non-licensed folks make the call and just make sure, we follow a checklist of things to identify any needs. Because, some of our families also don't want to ask for help, even though they probably need help. So we try to meet them where they are, just depending on what they need. I also happy to answer the question in the chat. Because of the geography of each guide program also has to be submitted to CMS. I don't see us expanding the Wake Forest program all the way to the eastern part of the state, but I do know that Life Care, the hospice in Wilmington, is probably the most likely closest guide program that can touch the eastern part of the state. I don't know their exact geography, but most programs cover multiple counties. So I will probably contact them first. And I didn't say this, but you can actually find all of the guide programs online on the CMS website. And happy to also have Heather share my slides, which lists with the names of the program and the city that they're based out of, but they probably go, a fairly wide area. The reason I think that there is some geographic limitation is that home visit component. While not everyone needs that home visit, we do have to account for travel time and, just a staff time if we're going to do that ourselves versus, partnering with another, say, home care agency to do that. There's just a little bit more logistics involved. And I know that too, because I do house calls and run our house call program. If that answers your question.
And then I think there was a question from Amanda Bulgarelli. I hope I didn't totally butcher that, but I think I did.
No, you totally nailed it. I
Oh,
was just
okay.
curious, Dr. Yang, if you have any connection with. Oh, perfect. That was what I was
Yeah,
looking for. Awesome.
yeah,
I'll connect you guys
exactly.
up.
That would be great. Yeah, thank you. Yeah, exactly. So Kelly is with the Lower Cape Fear Life Care Program. Yeah, that's the one. I've been in communication with Candy from Life Care, and also talking with Elizabeth from the Asheville Memory Care Program. And happy to get connected with other people if you know, because I think this is new for all of us. So I'm sure we can learn from each other.
I did have another question. I know you spoke about traditional Medicare and Medicare Advantage is not participating. What about people who are dually eligible, like have traditional Medicare and Medicaid?
Yep, they're eligible as
They're
long
eligible.
as,
Okay.
yeah, as long as traditional Medicare is their primary insurance. In fact, for dually eligible participants, we are also one of the, requirements is coordinating the care with their Medicaid social worker that
Okay.
deliver that, home and community-based services. So we have a couple people where we're actively trying to talk with their Medicaid social worker just so that they know what we're doing and we know what they're doing, especially if they're getting Medicaid personal care services.
Right.
Yeah, but the guide funding is in addition to that. So the guide funding kind of comes with itself, regardless of whether you have Medicaid or you don't have Medicaid.
And then, traditional Medicare pays what, 80% of most services. So how does a Medigap policy play into it? Or do you all not bill for that? You just take the Medicare per
Yeah,
diem?
there is no copay. This
Okay,
program is
excellent.
completely free for participants. In fact, we're not allowed to bill except for those codes, and we're reimbursed by those exact dollar amounts that I shared. That's all public knowledge. So it's not a program where I think anyone's doing it for the money, unless you're just like
Yeah,
so big that you have that economy of
right.
scale. But I would think that a lot of us are running a slight deficit in delivering the
Yeah.
program, depending on what type of, personnel you have. But I have also gotten some questions about, like, do we exclude anyone with really severe behaviors and things like that? And I say no. At least for our program, those are the people we're trying to reach, because really it's very difficult to get them medical care, and their families are suffering because a lot of times neurologists are not comfortable managing behaviors related to dementias, and there are so few
Mhm.
geriatricians, and their PCPs are overwhelmed, and they're kind of just, falling through the crack. So this would be a great program for those. I think, it comes back down to insurance is kind of the biggest eligibility limitation that we have found. We wish we could do this for Medicare Advantage program folks as well. And if anyone knows of Medicare Advantage liaisons, please send them my way. I would love to say, would you be willing to pay us the same as what Medicare pays for your beneficiaries? Because there is such a tremendous need. And we also know through literature that there are some income and socioeconomic differences between people who have traditional Medicare versus Medicare Advantage. Just when you look at the cost of, Medicare plus a supplement, plus all the, Part D, when you add all of that up, it is more expensive than paying for a Medicare Advantage plan that wraps it all
Right.
up. And so some of the patients that I see that we would really love to give them the guide program, we can't because they don't have traditional Medicare. And I do think that's something that we want to, bring that data to light, not only to Medicare, but to Medicare Advantage programs. And the reason why Medicare Advantage programs can not pay for it is because this is still a demonstration project.
Mm.
So Medicare at the end of the 8 years could say, yay, we're going to continue and make this eligible for everyone with Medicare, in which case then Medicare Advantage programs are required to offer what Medicare offers. But because it's a demonstration project,
Mm.
people could say, well, we'll just see how this pans out with Medicare.
Right. And I guess that's interesting too to me because Medicare Advantage, it seems like what you were saying about the guide model, the idea behind it was to also address social determinants of health, which we know are strongly related to socioeconomic status, et cetera. And so you would kind of think, well, Medicare Advantage is the more affordable choice for many people who are, facing socioeconomic issues. That would be the perfect, you know,
Yeah. But I
partner
think
or perfect
yeah,
client.
exactly. But I think it does come down to access of data. So Medicare,
Mm.
traditional Medicare data is squarely within the realm of the government,
Um,
versus Medicare Advantage data are all within each company. And so when you look at an evaluation of a program like Guide, it's going to be difficult to get, like, say, claims data out of a Medicare Advantage plan. And I know this because I do some research in claims-based data as well. It's very, very difficult to get timely claims data from Medicare Advantage programs, even if you pay them, just because
right.
they really have no incentive to share that with you.
Yeah, because they're a private entity, so they don't
Right,
have to share that with you.
right,
And I guess there's HIPAA consideration, but you could always anonymize the data, I would think. So I may
right.
have someone to put you in contact with. Let me do a little research. So,
Okay. Yeah. We would love to. We would love to chat with any potentially interested MA programs, because I do think it would be great. They could be the ones to say, well, among my MA competitors, we're the first one that can offer
mhm,
guide, and maybe it's good for their business.
gotcha. Yeah, exactly. Um, this seems like a really long demonstration project from my experience. 8 years is a long time. Any ideas about why it was such a long period of time?
I think it has to do with a couple of things. One is that it's difficult to look at dementia-related outcomes within a short period of time because
True.
depending on when people are diagnosed, if they're diagnosed in a mild stage, they might
Right.
not even they may not even
Right.
have behaviors associated with that dementia until, I don't know, 5 years out.
Right.
And so when it comes to, healthcare utilization, time to institutionalization within a long-term care facility, and some of the other quality outcomes, I think I would guess that they are the most apparent in people who have at least a moderate stage of dementia.
Mm.
And that's what we're seeing in the majority of our programs enrollees are people in that moderate stage where families are starting to see, okay, I need
Mhm.
more help now, but
Gotcha.
I don't have the funds to necessarily pay for and the mental load to arrange for
Right.
paid
Right.
caregivers and, all of that. So, yeah, I think the other thing is that this is a fairly complicated program to
Mhm.
implement, just
Yeah.
with all the delivery domains and the monthly billing, and it has taken quite a lot of sort of infrastructure build to
Mhm.
deliver even for the existing programs. So even among the programs that I'm hearing and in communication with, we're all kind of like still around 100 participants
Mm.
after this first year. Now a lot of that wasn't actively enrolling because we had to build the EMR and the billing and
Mm.
all of those partner organizations approvals, and that took forever. But we do hope that the longer we're in Guide, the more efficient we'll become and the more people we can help and enroll.
Excellent. I think there was something in the chat from Amanda about recently completed our first positive approach to care navigator training with a guide program or group in Alabama. So if anyone's interested, you can contact them using that email address and ask for the guide navigator training. And y'all are doing something new. It looks like, Amanda, you're going to provide brain health cognitive baseline screens. Oh, you could use volunteers to run the screens. Okay. So reach out to Amanda or the info at Teepa Snow if y'all are interested in that. Felt like I had another question for you. So basically, if someone needs, it gets to the point where their total care and the family just can no longer provide that care, even with the supports of Guide, and long-term placement is what is best for the person living with dementia, that's when Guide would step out, right? You'd have to disenroll that person. Is that how that works? Okay.
Correct. Yeah. So if they do move into long-term care, then they're um, no longer eligible for Guide. Although it has been surprising, at least for me, to know that a lot of memory care programs are considered assisted living, and
Mhm.
so Medicare actually says they are remaining eligible, even if they move into
Mhm.
a memory care, as long as
Yes.
that facility is an assisted living, we can
Yes.
still see them. And we do know that even after people move into long-term care facilities, the family caregiver is still doing a lot of care.
Yes.
It's just not necessarily hands-on or 24-hour care, but they're still, seeing their loved ones multiple days a week or making sure things get done in those
Right.
facilities. And they're still afraid to take a vacation because who else is going to go check on their loved one? So that actually, that respite money also applies to what the caregiver is doing. We just cannot use those respite funds to pay for their room and board and that memory care because it's not respite. That's your long-term, care cost.
Got you. So,
Amanda, I do want to add that I'm not at least able to open that SharePoint website, but I'm happy to follow up with the email. I don't know if other people are having the same problem. Oh, okay, never mind. Thank you.
Does anyone else have any other questions for Dr. Yang? No, okay. Oh, I did have one other question. Sorry. What about the like Leqembi? Can people receive that through Guide or not?
Yeah, people can, but I have been trying to tell people within even within my own institution, Leqembi and the monoclonal antibodies are kind of like chemo that you get every 2 weeks.
Yeah.
It's palliative chemo, it doesn't cure the
Right.
disease.
Right.
And then Guide is kind of like the palliative care that sometimes comes with cancer care. I don't usually see people getting both at the same time because their goals are very different.
Mhm.
One is about slowing the disease and,
Right.
willing to accept the burden of getting that, every 2 week or,
Right.
the other one is every month infusion for a long period of time and the very mild stage of dementia.
Right.
But Guide is really, I think, more for people who are experiencing behaviors related to dementia and families are needing that respite care. I would guess that a lot of people getting the infusions are mild enough in their disease. They're still able to do some of those infusions on their own. They can
Right.
still drive,
Right. Yeah.
especially if they have just mild cognitive impairment. So technically, yes, you can get both, but in practicality, I haven't seen people get both.
Okay. Yeah, I was wondering about that because of the staging. So I didn't know, you know, the clients that you're or patients or beneficiaries that you're seeing if they what stage they fall into necessarily.
Yeah, most of ours have been moderate stage. We do have somewhere about 15% who are in the mild stage, and then the rest in the severe stage. So they are probably getting, nursing home level of care at home provided by their families. Um,
Gotcha.
I think some of that is also financial.
Hmm.
Lack of long-term care
Right.
funding and being too rich for Medicaid.
Right.
And so, yeah, unfortunately, we try our best to give them the respite. And that respite money renewals every year. So for people who are enrolled this year, they have until June 30th to use up their $2,500 because it does not roll over, and then they get another bolus of
Okay.
$2,500 the next year.
Gotcha. So they have to use it within that. Is it a calendar year or a fiscal year?
It's July to July.
Okay. And so it doesn't roll over. So if you don't use it, you lose it basically.
Correct.
Got you. Okay. Well, thank you so much, Dr. Yang. Excellent information. So exciting to see things moving forward for people living with dementia and their caregivers and families in this way. And the support is wonderful. Um,
Thank you for having me here, and great to see all of you.
yes, and thank you for making the commitment to be able to present, even though you're in transit to a conference. I hope you have a wonderful conference and safe travels home.
Thank you. You guys
You're
take care.
welcome. You too. Take care. Anybody have anything they wanted to share? Any updates on their work in the dementia-friendly space? I was just on a call with Billy Breeden. I think you're on here. Are you, Billy?
Yes, I'm on here, Heather.
Hey, how are
Hi,
you?
fine, how are you?
Good. So how are things going out west in terms
They're
of the
fine, but
recovery and
yeah,
people living
Buncombe
with
County's
dementia?
still focused on the recovery efforts, so that's a big push right now. But as related to dementia friendly, we have the Dementia Friendly Western North Carolina
Hmm.
committee, and right now we're going through a bit of a transition because we don't have the capacity to do as many dementia awareness sessions as we would like. But we're still figuring that out and trying to recruit more members to the committee. But our focus, we'd like to turn our attention is to like recognizing businesses as dementia friendly. So we're going to start, I think we're going to start doing that, but and really included in that, when you go to the businesses, you do um, provide information about dementia and how to support people living with dementia. So it's kind of a combined effort.
Got you. Well, on the dementia-friendly front, thank you for sharing that, Billy. And anybody else who has anything they want to share, I see Kelly Cahill and Jennifer Parnell and Lori Simmons and Natalie. Anybody have anything else? I'm not trying to call anybody out, but Kitra, did you have anything else you wanted to share about the age-friendly health system work you all are doing with IHI or? Diane, I see, is on the call too. So, Dee Dee. I do see. So, Kelly, we do not have decals for the businesses who go through DFA. We don't have any funding for that. So, a lot of what is occurring out in the community is through the goodness of people's heart and their commitment to the work. So right now we don't have funding for that. And I'll give you all an update from US Aging and Dementia Friendly America. But Kitcher, were you gonna share something?
Can you guys hear me?
Yes.
Okay, sorry about that. I couldn't get
No
off mute.
worries. No worries.
So we are finishing up our last 3 sessions for the IHI grant for our dementia prevention detection for patients with dementia with behavioral disturbances. We have found and had very, very good outcomes management. We went from about 35% use of chemical and physical restraints with patients with dementia with behavioral disturbance to down to almost 2%. And so our next goal is to roll it out to some of the other inpatient units. So the difficult thing that we have found and realized is because we have cumulatively done this work from when geriatrics first came to Hillsborough. So it's been about 7 years, and I have been blessed to have staff who have been here for a long time. My average nurse has been here greater than 6 years, and so we have to start some of the groundwork with some of the inpatient staff that is in other areas of just teaching them how to do delirium detection, even before we get to how to do the work. And so, but we're excited about that. We've started gathering the information to do the education, and hopefully we've already have one of the units who has said that they would love to promote it, and our hospitalists are super, super excited because there is so much difficulty and, of course, as we know, poor outcomes with our patients who do end up in restraints or use physical or chemical restraints that long-term cause so many bad effects, including death. And so we are very, very excited about our next phase of this work. So more to come. Of course, we're always working on new things. We're amongst the UNC healthcare system working on development of 4-H work for our age-friendly work. We on Fort Bend Tower already have a 4-H template that we utilize, and so we are sharing that with the organization to hopefully spread that also. So lots of great work for our geriatrics to come.
Excellent. And I just always, and I hope you're okay with this, quote you that you have been able to reduce restraint usage on your unit by 75%, which is amazing. So
It is.
hats off to
Truly
you.
amazing. People can't believe it that we actually have these patients, and they are sometimes in the ED and in other areas, and are with sitters and are in
Yes.
4-point restraints. So as soon as they get here,
Yes.
we take them out of restraints. So
That is fantastic. Love that. Seen way
I
too
have,
many people in restraints.
I have a question. Can you hear me? This is Jenny.
Yeah. Hi, Jenny.
Hey, I wanted to talk to Keisha to say, have you done any type of poster presentations or anything like that? Because I would highly encourage you to share your work and take it to different. I mean, I know we had a speaker, Heather spoke at NCO&L, but I would really love for you to do that, and that would just get other hospitals to share throughout the state and the nation, because it is the fear of taking a family member to the hospital that has dementia is overwhelming. Just knowing what would happen to them to be put in restraints, and a lot of times staff don't know what to do. So kudos to you and your team, and I hope you will do some poster presentations and share that.
Oh, absolutely. Thank you for saying that. We are focusing on some nursing promotion. We did a lot of interdisciplinary work with our medical team, and so our service line chief has published tons of work, and I told my director about 3 weeks ago, who she just walked in my office, and I was like, yeah, we need to have published some stuff. We need to get some posters out. So that is actually our next phase of what we are working on, is making sure that we're talking about the work that is actually my staff who's actually doing that work and trying to maintain these patients from having to have those bad results. So thank you for saying that, and hopefully I will have more to share with you guys in the upcoming months.
Excellent news. And Mary Hall, I see that you're on. I don't want to put you on the spot, but did you have anything to share about the dementia-friendly work that you all are doing down east?
Yeah, thanks for asking. We are also engaged in the age-friendly uh, metrics that we're trying to capture for CMS. I'm so real excited that we're finally paying attention to our older patients. No offense. But for dementia friendly, I am hopefully tomorrow going to get my final sign off to do the virtual dementia tour here at the hospital with staff. In the hospital version of that. So we've been doing some education with, we have a whole new observer program here at the medical center, and one of our special care units that sees a lot of dementia patients. We're doing some training with those staff, but then we'll do this virtual piece, which will kind of tie it up in a nice big bow for them to really have some deep appreciation for this population. So super excited.
Oh, that's fantastic news. Thank you. Wonderful to hear.
Thanks for
Anybody?
asking.
Yes, of course. I don't want to leave anybody out. So, Lori Simmons, anything to share with your community work or your dementia-friendly work?
Hi, nothing new that's going on in our area. We're still just kind of plugging along with our continuous training on new staff as they come in with our dementia-friendly orientation, and just trying to keep things moving along.
Well, that's huge too, really. Diane Denny, I see you're on. Did you have anything to share about your dementia-friendly work out east?
Just continuing to train businesses and restaurants, and excuse me, going back now and retraining some. They've got new staff, and so we're going back and retraining some others as well. And just trying to continue going out in the community. We're getting ready to do a dinner
Oh,
for folks living with dementia and their caregivers, and it would be specifically just for them, so that
right.
they would have a safe environment,
Mhm.
that they could enjoy a nice dinner out.
So like a memory cafe?
It's at the country club, and
Oh,
it's just dinner. Again,
okay.
white tablecloth, flowers, and just
Oh,
have a really
lovely.
nice dinner out, in a safe environment with no judgment.
Oh, that's beautiful. I love that. If you're interested in, looking at a memory cafe, please reach out to me and I can make some connections for you. There's, some in our state, and then there's some other states that have developed some, toolkits. So feel free to reach out. Anybody else have anything to share?
Can I mention one other thing? And I don't
Yes,
think I did this.
please.
The North Carolina Museum of Art has a creative impressions program. And they came out in February and they're coming again the end of this month. They bring what she brought last time was a copy of course, a Monet painting.
Oh,
And it was for a caregiver and their person lived with dementia. And they talked about that painting, and it was amazing to see what different things people saw in that picture. And then they created an art piece led by this person from the museum. And that is available to anybody in North Carolina. So if anybody's interested, you can connect with them. It was really fun.
that's amazing. And that's the North Carolina Museum of Art in Raleigh.
Yes, ma'am.
Okay, because I know that there's the Nasher Museum, and they don't come to you, you go to them, but they have a special program for people living with dementia and their caregivers. So, anybody else have anything to share?
Heather, you mentioned the memory cafes. We're excited in Pitt County. Our senior center is just starting one, and they're going to have similar where they're going to have a dinner for both the caregiver and the person living with dementia, and then they're going to separate out, and the participant will do some sort of activity, and the caregivers will have their kind of support group time. So it'll be really fun.
Oh, excellent. I volunteered at a memory cafe. It's been a couple months ago, and it was lovely. They had a singer, and she sang some big band and some, 50s and 60s music, and people were dancing, and it was really great. It
Yeah.
was a lovely experience. So about US Aging, Dementia Friendly America, I just got an email today, they're going to start having some work groups to look at the application process, I believe, for obtaining the Dementia Friendly Communities designation. So more to come on that, right? Right now you can reach out to me if you're interested, or you've got a community interested in completing that application. I've gotten some good tips from my colleagues from across the country about completing the application. It looks really daunting, but I think there's ways to break it down into more manageable pieces of work. So always happy to do that. And then our Dementia Friends program is, out, and people are providing sessions. I know Kelly Cahill's provided some, Candace Gray, I believe LaTanya Smith, and I don't want to leave anybody out. So, but yes, thank you so much. So I guess unless anyone has anything else to share, I can give you back, what, 17 minutes? No, 18 minutes of your day. And we're going to adjourn until August 6th, 2025, 10 a.m. And I believe, Christy, you're on the line, aren't you? Christy Cooper is going to present to us about people living with Down syndrome and Alzheimer's disease. Christy, did you want to say anything else about that?
No, we're just excited to be able to do that. We're bringing in a specialist at our brand new UNC Down syndrome clinic, who is going to be speaking to some of the differences between individuals who don't have Down syndrome and have dementia and those who do, because it looks a little bit different. So she'll elaborate on that in August.
We're really excited about that. Thank you so much for being willing to do that for us. And I hope you all have a great day. We'll get the meeting minutes out to you, a link to the recording, and the slide deck from Dr. Yang. So have a great day, everyone.
You have a great day.
Thanks, you too. Take care.